Welcome to this explainer. Today, we're getting right into the weeds, specifically those hyper-dense algorithmic boundaries and exception rules that totally dictate preventive healthcare. As clinical peers, we know preventive medicine isn't just a basic list of guidelines, it's a rigid choice architecture. We're stripping away all the generic filler today to look strictly at the physiological details, the exact screening boundaries, and those sneaky variance traps where secondary prevention either saves a life or triggers an avalanche of totally unnecessary interventions.
So here's our roadmap for today. We'll hit malignancy screening matrices, immunization logic and host limits, occupational exposures, and finally, high-yield clinical variance traps. Let's get right into it.
Module 1, Malignancy Screening Matrices, looking at both the baseline standards and the key exceptions.
All right, consider the choice architecture for colorectal cancer screening. For your average risk patient, that boundary is set in stone between ages 45 and 75, right? The gold standard is a colonoscopy every 10 years. But if your patient prefers stool-based testing, a FIT test has to be done annually. Or you can go with a multi-target stool DNA test like Cologuard every 3 years. That's our basic everyday matrix.
But here's where we hit our first major clinical variance trap, and it's a big one. Just one subtle detail in family history completely flips the management pathway. If your patient has a first-degree relative with colon cancer, you have to completely toss out that standard matrix. Instead, you've got to initiate a colonoscopy at age 40 or exactly 10 years prior to that relative's age of diagnosis, literally whichever comes first. And that relaxed 10-year surveillance interval? Scratch that. It collapses down to a highly aggressive 5-year cycle. It's an algorithmic fork in the road you absolutely cannot afford to miss.
Now, let's look at lung cancer screening with annual low-dose chest CTs. The algorithm here is ruthless. Every single parameter has to be met simultaneously. The boundaries are absolute. The patient must be between 50 and 80 years old, have a 20-pack-year smoking history, and they either currently smoke or quit within the exact last 15 years. If a patient quit, say, 16 years ago, the algorithm strictly commands you to stop. No exceptions.
You might be wondering, why are these boundaries so incredibly rigid? Well, let's do a quick thought exercise. Say you run a chest CT on a 75-year-old heavy smoker, and then you run one on a completely healthy 25-year-old non-smoker. The sensitivity and specificity of the CT scanner itself, obviously that doesn't change. But what does fundamentally alter? The positive predictive value. Because the pretest probability in that high-risk smoker is so massive, the positive predictive value of their scan shoots way up. If you screen that 25-year-old, you're practically just guaranteeing false positives.
Let's contrast those parameters with the breast and cervical matrices. Mammography locks in from age 50 to 74, occurring every 1 to 2 years. Cervical screening, on the other hand, kicks off right at age 21 with cytology every 3 years. But notice the hard shift right at age 30. That's when the algorithm introduces HPV co-testing, which stretches the safe interval out to 5 years. And that brings us to a massive red flag variance trap for cervical screening. You never, ever order HPV co-testing in a patient under 30. Why? Well, transient HPV positivity is just incredibly common in that specific demographic. If you prematurely order that test, you're almost guaranteeing a false alarm, which sends the patient spiraling down a cascade of unnecessary, invasive colposcopies. In this case, the algorithm is literally protecting the patient from the test itself.
Okay, moving on to Module 2, Immunization Logic and Host Limits.
When we start parsing pneumococcal vaccines, we aren't just memorizing brand names here, we're actively manipulating the cellular response. Conjugate vaccines, like PCV15 or PCV20, trigger T-cell-dependent B-cell activation. Basically, by conjugating the polysaccharide to a protein, they generate robust mucosal immunity and a really solid long-term memory. On the flip side, PPSV23 is purely a polysaccharide vaccine. It relies on a T-cell-independent response, so you get broader coverage, sure, but a much weaker and significantly shorter-lasting immune memory.
So, this core physiological difference completely dictates the chronological branching logic for adults 65 and older, or for compromised hosts. The choice architecture forces a decision point. You can either give a single dose of the broader conjugate PCV20 and be done with it, or you lay down a foundation with PCV15 first, followed by PPSV23. If you choose that two-step path, time becomes your critical variable. For an immunocompetent adult, you've got to wait a full year to optimize the response. But for a severely immunocompromised host, like an HIV patient, the algorithm tightens up. You wait just 8 weeks before giving PPSV23 so you can rapidly close that coverage gap.
And speaking of compromised hosts, here is an absolute, non-negotiable safety boundary. Live attenuated vaccines, we're talking MMR, varicella, the intranasal flu vaccine, are strictly contraindicated in pregnant patients and hosts with profound cellular immunity deficits, specifically a CD4 count below 200. If you administer a live vaccine here, that's not prevention anymore. You're essentially handing them an iatrogenic infection.
Let's switch gears to Module 3, Occupational Exposures and Cancer Risk Algorithms.
All right, let's run a rapid-fire comparative analysis on environmental particle profiles. Asbestosis is typically driven by exposures in shipbuilding, roofing, and plumbing. Physiologically, the damage gravitates downward. It causes interstitial fibrosis in the lower lobes alongside those pathognomonic ivory-white pleural plaques. Silicosis, on the other hand, hits sandblasters and miners. It moves upward, presenting with upper lobe nodular opacities and those classic eggshell calcifications. And then there's coal workers' pneumoconiosis, which mimics silicosis by moving upward with small nodular opacities and coal macules.
Now, when those chronic exposures eventually mutate into malignancy, the results are just devastating. Think about a massive bronchogenic carcinoma presenting as a dense solid mass in the upper lung field. This isn't just an abstract theory. This is the literal physical end-stage complication of synergistic occupational exposure.
And right here lies one of the most notorious clinical traps, the malignancy dissection boundary. Yes, malignant mesothelioma is highly specific to asbestos. We all learn that. But say a 65-year-old former shipyard worker with a smoking history develops a new lung mass. What is it? Statistically, it is overwhelmingly bronchogenic carcinoma. The baseline incidence of standard lung cancer is just exponentially higher, especially because of that massive synergistic multiplier with tobacco use.
Silicosis carries its own very specific variance trap. Silica particles are brutally toxic to alveolar macrophages, which are the exact cells responsible for containing mycobacteria. Because silicosis so profoundly impairs macrophage function, there's an absolute clinical mandate. The very second you diagnose silicosis, you absolutely must actively screen that patient for latent tuberculosis using an interferon gamma release assay or a PPD.
Finally, Module 4, High-Yield Clinical Variance Traps and Reconciling Errors.
You know, a truly crucial point we must embrace as clinicians is knowing exactly when to hit the brakes. The algorithm makes it crystal clear. You halt routine screening, whether we're talking breast, colon, or prostate cancer, once a patient's competing comorbidities limit their life expectancy to less than 10 years. Because of lead time bias, the benefits of early detection are going to be completely eclipsed by competing mortality. Screening them at that point doesn't help them. It honestly just causes diagnostic harm.
But on the flip side, let's look at a scenario where you actually have to hit the gas and accelerate the timeline. We established earlier that the standard colonoscopy interval is 10 years, but specific histopathologic triggers force you to abandon that rule entirely. If you resect an adenoma larger than 10 millimeters, or if the pathology report comes back showing villus histology, high-grade dysplasia, or multiple serrated polyps, you slam that 10-year surveillance window shut and drop it down to a strict 3-year repeat cycle.
Let's apply that to a real-world scenario. Imagine you have a healthy 52-year-old man with a completely excised 3-millimeter polyp. Tiny, right? But then histopathology returns showing dysplastic-appearing cells. Because of that one singular variable, dysplasia, the 10-year rule is completely void. The algorithmic choice architecture immediately forces a repeat colonoscopy in exactly 3 years to prevent any interval cancer from developing.
Let's wrap up with a bit of a provocative thought exercise, something that really cuts to the core of our specialty. If we were to deploy a highly precise screening test globally, catching cancers way earlier than ever before, does that actually change the true underlying incidence of the disease in the population?
The answer is a resounding no. Early detection is secondary prevention. It's just catching structural alterations after they've already begun. It doesn't actually lower the incidence rate. The only way to truly lower incidence is through primary prevention, actually altering the risk factor exposure, like smoking cessation or sun protection. So as we master these incredibly complex screening matrices and granular algorithms, let's not lose sight of the big picture. True preventative health architecture lies in stopping the exposure entirely long before the pathology ever has a chance to take root.